Good afternoon and welcome to another satellite seminar from the Institute of Health Studies, being broadcast from the University of Plymouth TV studios. This seminar has the broad heading Clinical Outcome Measurement in Health. Determining the properties of an outcome measure is essential in order to select the most appropriate tool for use in research or clinical practice. In the studio today we have three speakers who will give examples from their own work or the literature about these issues. Veronica Maynard is a physiotherapist and will present work from the analysis of gait within a laboratory setting. Jenny Freeman is also a physiotherapist and will discuss quality of life measures. And lastly, Simon Spooner is head of podiatry and he will give us examples from the literature. In the studio to discuss the three presentations, we're very pleased to welcome Jeremy Homart, who is consultant neurologist at Derriford Hospital in Plymouth and who is the founder of the Outcome Measurement Unit at the Institute of Neurology in London. Welcome, Jeremy. So we will first have the three short presentations and then come back here for discussion. Now, of course, we want your participation through questions and comments. You don't have to wait until the discussion period. You can contact us at any time by telephone on 01752 233 646, or you could email us direct on tvstudio@plymouth.ac.uk. If for some reason you can't get through to the studio with your telephone, you could always phone a friend and ask them to email your question or comment. So we go over now to Veronica.
Thank you, Ray. This afternoon we'll be talking about the properties of outcome measures used in clinical and research practice. It is important to understand the psychometric properties of outcome measures in order to determine their strengths and limitations. This afternoon I'll be talking about the psychometric property of reliability, and we'll be talking about how we measured reliability using a gait analysis system in a laboratory setting. Following on from me, Jenny Freeman will talk about validity and appropriateness of outcome measures using the SF36 outcome measure. And finally, Simon Spooner will talk about responsiveness using examples from the literature. I'll first talk about the general properties of reliability and how they're measured. Reliability refers to the consistency or repeatability of a measurement taken under the same conditions. It's really the extent to which the measure is consistent and minimises random error. And there are a number of factors affecting reliability. These include the instrumental reliability, so the reliability of the instrument or the measurement device itself, rater reliability, the reliability of the rater administering the device, and finally response reliability, which is the reliability or stability of the measure being measured. There are a number of sources of error that will affect reliability of a measurement tool, and these are a list of them here. Firstly, there's measurement error. That would be the difference between a measurement and its true value, and this is determined in part by the accuracy and resolution of the measurement device itself. There's also systematic error. These will be due to biases resulting from factors such as instrumentation and deviations from the protocol. And thirdly, there's random error, which would be measurement errors that occur for no particular reason, such as by chance or unavoidable errors, and these may be reduced by repeated measurements, so averaging. There are three broad categories of reliability, and reliability testing is usually performed to assess one of the following. There's equivalence or reproducibility, stability or repeatability, and internal consistency or homogeneity. And I'll be talking about the first two of these and how we have assessed these categories of reliability in a particular study. This slide illustrates these categories of reliability and how they're actually measured. We have equivalence or reproducibility here where my hand is, and this is measured using inter-rater reliability type studies. We have stability or consistency over here, and this is measured using intra-rater or test-retest reliability type studies. So I'm now going to talk about a study that I have been involved in, looking at the intra-rater reliability of a motion analysis system used in a laboratory setting. We used a system of computerized gait analysis. This is used to make objective measurements or observations of human movement, and very often it's used in measuring patients' performance before and after a particular intervention. And following this, recommendations are often made for a particular intervention. For these reasons, it's particularly important that we establish the reliability of the movement analysis system itself. There are a number of studies that have looked at the reliability of motion analysis systems, such as that by Kadabra et al. In 1989 and that by Steinwender et al. in 2000. But to date, there have been no published studies looking at the reliability of the CODA MPX motion analysis system. The first study that we looked at was that we undertook was an intra-rater reliability study. We looked at 10 healthy volunteers, 5 males and 5 females, and we undertook 3 recordings on 3 separate occasions. That was on the morning and the afternoon of the same day, and then a week later. There was a single trained observer who was trained in use of a particular protocol, standardized protocol. The inter-rater reliability study was undertaken in 19 healthy subjects, 4 female and 15 male, and we had three separate observers trained in the use of the system and the use of the protocol. Let's just go back. This slide just illustrates the type of this sagittal plane movement or data that we would get from the CODA motion analysis system. In undertaking the studies, we undertook the following procedure. Sorry. We looked at certain spatiotemporal parameters, such as walking velocity, duration of stance, and duration of swing. We also looked at kinematic variables. These are variables relating to movement of the limb segment, angular acceleration, and velocity. We looked at kinematic variables at the hip, knee, and ankle angles at initial contact, mid-stance, and mid-swing. And we also looked at kinetic variables, which are moments and powers at the hip, knee, ankle, and these were at initial contact and mid-stance. And the previous slide illustrates these 3 points in the gait cycle. The first illustration here is the point of initial contact. The second one is the point at mid-swing, and the third one at mid-stance and mid-swing. The analysis involved looking at sagittal plane data only. Sagittal data is the data that is received through the plane where you're looking at an individual from the side, so you're dividing the body into right and left halves. The analysis that we used were Bland and Altman methods, used particularly to measure absolute reliability. We also undertook intra-class correlation analysis to determine consistency and agreement among ratings. The intra-class correlation coefficient is measured using ANOVA, and it's calculated using variance estimates, variance between subjects to sum of error variance and within subject variance. This graph illustrates the type of data we receive from the sagittal plane view, and it illustrates ankle angle movement during a single gait cycle. And the first point here is initial contact, followed by mid-stance and mid-swing. So the results of the first study, the intra-rater reliability study. The results indicated that we had good agreement for spatio-temporal data. That's, if you remember, looking at velocity, duration of stance and duration of swing. So there was good agreement there with the intra-rater study. Generally, there were low intra-class correlation values with ICC values of less than 0.75 for all parameters. That's kinetic and kinematic. The Bland and Altman plots produce reasonable agreement for kinematic data at the ankle and knee. For example, at the ankle joint, at initial contact, mid-stance and mid-swing, Bland and Altman limits of agreement were within plus or minus 7 degrees. However, limits of agreement at the hip were much wider, with agreement being within plus or minus 18 degrees. Findings from the inter-rater reliability study were fairly similar. There was generally good agreement for spatiotemporal parameters with ICC or intraclass correlation values of greater than 0.7. There were lower ICC values and wide limits of agreement for kinematic data, especially at the hip. The ankle-angle joint movements at initial contact, mid-stance and mid-swing indicated agreement within plus or minus 7 degrees, which is similar to the intra-rater study. However, limits of agreement at the hip were around plus or minus 17 degrees, so again they were wider. These two graphs illustrate the Bland and Altman plots. Along the y-axis, up the top, there's the angle difference between morning and afternoon, so between two measurements. And along the x-axis, there is the angle mean between morning and afternoon. The advantage of the Bland and Altman plots are they provide a visual view of the level of agreement between subsequent measures. They also give us an indication of bias and outliers in our measurements. So there are a number of factors that may affect reliability, and that have affected reliability in this instance. These are errors associated with marker placement. There may be inaccurate, inconsistent marker placement despite adherence to a standardized protocol. The markers used in the system are skin-based, and there are obviously skin movement artifacts. And soft tissue motion during the movement itself can introduce systematic errors. There's also the consideration of the natural variation in the individual gait cycle, and this may have had more effect on the intra-rater study than the inter-rater, where we looked at walking between morning and afternoon and then a week later. Sampling rate is also a factor that could affect reliability, and that it's important to have a high sampling rate in order to capture accurate data. So some recommendations following our study in relation to motion analysis. We recommend the use of a standardized protocol for marker placement, and that observers are well trained in the use of this protocol and in identifying anatomical landmarks and placing markers. We also recommend the averaging of a minimum of 3 gait cycles, and this has also been suggested by previous researchers such as Winter in 1984. And it's also suggested that you interpret with caution data from a single cycle because of the natural variability in gait and other factors. So general recommendations which would apply to anyone involved in using outcome measures either in clinical research, in clinical practice or in research, are the use of standard protocols, strict adherence to the protocol with any deviations from the protocol being accounted for. There should always be adequate training of observers or raters in the use of equipment and in the use of the protocol. Averaging may be required to overcome some variability in measurements. And it's important also to determine the level of error in order to determine real change in a parameter. It's also important to assess the reliability before measurement tools are used either in research or clinically, and that reliability is assessed in the population under study. And it's also important to be careful not to interpret with caution findings from other studies that have used single estimates of reliability, such as reliability coefficients, in different studies, and also be careful about their clinical application and consideration of the population in which they've undertaken the study. So we'll now move on to Jenny's presentation. We'll be talking about the validity and responsiveness of outcome measurement tools. Thank
you. Good afternoon. As Veronica said, it's my remit today to talk about the validity and the appropriateness of measurement instruments. In doing so, I'll present the results to you of a study that we undertook when I was at the National Institute of Neurology, and whom Jeremy Hobart was a key co-investigator. Firstly, a definition of what is meant by validity. Validity describes the extent to which the measure measures what it's intended to. Traditionally, validity looks at content validity, or the comprehensiveness of items within the measure. Criterion validity, which examines the extent to which the measure provides results that are consistent with the gold standard. And construct validity, which is a validity that we examined in this study. Construct validity involves forming theories about the attribute and then assessing the extent to which the measure provides results that are consistent with the theories. In summary, determining the validity of a measure is not an all or none phenomenon. Knowledge of a measure's validity is accrued over time. The validity, information about the validity is developed as information about the validity constantly evolves. And some people determine the validity of a measure has been likened to undertaking a detective work, where pieces of the mystery are solved in order to understand who committed the crime, or to a jigsaw puzzle, where pieces of a jigsaw are gradually added in order to complete the whole picture. Appropriateness is a term which is used to describe whether the range of the construct measured within the sample is similar to the range which is covered by the instrument. And in essence, this reflects the relevance of the instrument to the population being examined. For example, a useful outcome measure must be able to demonstrate change, and in doing so must be able to pick up deterioration in subjects, and also to pick up improvements that the subject may make as a result of an intervention. And appropriateness is assessed by looking at the scale score distributions of the instrument. Now to give you a brief explanation of the SF36, which is considered the gold standard generic measure of health status or health-related quality of life. The SF36 has been adopted and disseminated worldwide. It's available in a wide variety of languages and used in numerous countries, both to compare and contrast different conditions within different settings, and also to evaluate the effectiveness of interventions. There's a standardised UK version of the SF36, as well as a US version of the SF36. And similarly, norms have been determined for both a healthy UK population and the US population. The SF36 is comprised of 8 multi-item dimensions that you can see here. All items are coded and transformed onto a scale of 0 to 100, where 100 is considered the worst possible health status, and wherein 0 is considered the worst health status, and 100 is considered optimal health. It's a self-report measure. In addition to these 8 dimensions, a score can be subdivided into 2 component scales, a physical component scale and a mental component scale, and these are described as summary component scales. Although proven to be reliable and valid in a wide range of conditions, relatively few studies have evaluated the use of the SF-36 in multiple sclerosis. And most of these studies that have been undertaken have looked at the usefulness of the SF-36 in describing its impact of MS on quality of life. Few have evaluated its use as an outcome measure in clinical trials of MS. We therefore decided to explore the reliability, validity, clinical appropriateness and responsiveness of the SF-36 in MS patients within a healthcare setting. 150 patients with clinically definite MS participated in this ethically approved prospective study. Consecutive patients were recruited from 3 different sources within a healthcare setting, and these sources were a weekly outpatient clinic, an inpatient neurorehabilitation unit, and those admitted under a single consultant for acute care to the inpatient wards. 106 patients were assessed at a single point in time, and 44 rehabilitation inpatients completed the measures twice, pre and post a period of inpatient rehabilitation, in order to determine responsiveness. In order to undertake the kind of detective work that's required for validity, then a broad range of information was gathered. Demographic and diagnostic details were recorded for all patients. In addition, the level of disease severity was undertaken by the expanded disability status scale, and this was scored by a neurologist. Health status was scored by the short form 36. Levels of physical disability were scored by the functional independence measure, handicap by the London Handicap Scale, and emotional well-being by the 28-item General Health Questionnaire. Each of these other measures have all been previously used in MS studies and have been shown to be reliable, valid, and responsive within a rehabilitation setting. Convergent validity and discriminant validity. Convergent validity was assessed by determining the relationship between SF-36 dimensions and other instruments measuring similar constructs. For example, we would expect the physical dimension of the SF-36 to correlate substantially with the motor subscale of the functional independence measure, but weakly with the General Health Questionnaire, which looks at emotional well-being. With regard to group differences validity, this is the ability of the measure to discriminate between different groups, and this was investigated using a one-way ANOVA. For example, to provide evidence of group differences validity, then we would expect that patients categorised into the mild subgroup would report lower scores, in the severe group, would report lower scores on the SF-36. Compared to those who are categorised in the mild group, according to the EDSS. Assessment of construct validity was also undertaken through hypothesis testing. And hypothesis testing examines whether the results are in line with theoretical examination, with expectation. We therefore made a number of hypotheses to test this. For example, that patients independent in daily care would score higher on the physical dimension of the SF-36 than those who were dependent on care. Or that patients that scored greater than 5 points on the GHQ, which indicates that they're emotional distress, would score lower in the emotional health dimensions than those patients scoring less than 5 points. To determine appropriateness, we examined the scale score distributions of the 8 dimensions and also of the 2 component summary scores, as well as of all the other measures. Distributions were looked at with regard to the range, the mean, standard deviation of scores, as well as the floor and the ceiling effects. And here are our results. The sample characteristics were as expected of a typical MS population. The average age was 45 years, 68% were female, 50% were in the secondary progressive phase of the disease. And our total sample had a mean EDSS of 5.7. With regard to convergent and discriminant validity, these aspects of validity were supported. As expected to see, substantial correlations were shown between related scales. For example, the FIM with the SF36 physical function showed a correlation of 0.68. And similarly, substantial correlations were shown with the EDSS with R values of 0.82. With regard to discriminant validity, then weak correlations were demonstrated with unrelated scales. For example, an R value of only 0.26 between the GHQ and the SF36 physical function dimension. Group differences validity was also supported. Significant differences were demonstrated in health status at different levels of disease severity. With regard to the hypothesis testing, as hypothesized, patients requiring carer assistance reported lower scores on the physical dimension, and patients scoring greater than 5 points on the GHQ reported lower SF36 emotional scores, demonstrating emotional distress. With regard to appropriateness, the results were particularly interesting. For the total sample, the scores span the entire spectrum of the available range. When patients, however, were subdivided into subgroups according to their disease severity, namely into mild, moderate or severe disease severity, then the distribution of the scores altered markedly. For example, in the physical functions scores, the scores spanned only the bottom 20% of the available range for the severe group. Likewise, the means fell substantially outside the midpoint of the scale. For example, the midpoint of the scale for the physical functions dimension is 50. In the severe group, the mean was only 4.4, demonstrating severe physical disability. And the mean for the moderate group was 22.9, so it's really quite substantially outside the expected mean of 50. In contrast, score distributions for the other measures, the FIM, the GHQ and the London Handicap Scale, scanned the entire range both for the total sample and for the subgroups, and the means were within were loosely clustered around the midpoint of the scale. Now, probably most importantly from a clinical perspective was that there were significant floor effects noted in 4 of the 8 dimensions, and this was in the total sample. It's reported that floor or ceiling effects greater than 20% are significant, and these occurred in the physical function dimension, physical role limitations, emotional role limitations, and in the bodily pain dimensions. And again, we saw that these floor and ceiling effects were particularly marked when patient selection was restricted to a narrow range. And this is really crucial to note, because most studies, patient selection is narrowed to a restricted band of disease severity. So, for example, in the physical dimensions, 52% of the severe group floored out, and in the physical role limitations, 84% of the population of the severe group had received the lowest or scored the lowest possible score. Similarly, there was a ceiling effect of 45% in the role limitation section of the mild group. But it's notable that this wasn't simply in the extremes of the groups, it wasn't simply in the mild and the severe groups, but it was also in those in the moderate groups where floor and ceiling effects were displayed. And there are important implications to this finding, which I've attempted to illustrate here. In a scale where it should be able to demonstrate the ability to improve or to deteriorate, the spectrum of the scale should be able to to demonstrate that if we're to see changes either in terms of improvement or deterioration in patients. If people actually score the lowest possible score, the floor effect, then there's nowhere for them to deteriorate, although there is considerable room on the spectrum of the scale for them to improve. And this is particularly significant, of course, in a progressively deteriorating condition, such as MS. And conversely, if a high percentage of people score the top possible score, then there's nowhere for them to improve, to demonstrate that improvement may have occurred as a result of the intervention. Now, if the floor and ceiling effects are high, it suggests that the spectrum of the scale is too limited to detect change, some of the changes that may occur in MS. It therefore follows that high floor and ceiling effects may limit the potential responsiveness of an instrument, particularly when the sample is restricted to specific subgroups or settings. And this information is clearly crucial to understand if you intend to use the measure as an outcome measurement instrument. So our recommendations are that the generic measures should be tested for specific populations and for specific purposes. Furthermore, when evaluating the health status in MS, the SF36 should be supplemented with other relevant and validated measures to ensure that measurement is comprehensive and valid. So in summary, clinicians and researchers are increasingly being encouraged, indeed it's inherent within professional standards and guidelines, to use outcome measures to evaluate their interventions. Researchers similarly must ensure that measures that they're using evaluate the effectiveness of to evaluate effectiveness are fit for the purpose. It's well recognised that no measure is perfect. Understanding the strengths and limitations of a measure is crucial to both clinicians and researchers, so that they can select the most appropriate instrument and that they can understand the results that they have generated. Thank you. And now I'd like to hand over to Simon Spooner, who will be talking about responsiveness in a measure.
Thank you, Jim. Thank you. Perhaps the most important criterion for the selection of a measure to evaluate patient outcomes is whether it is responsive to changes that would be considered significant by patients and/or practitioners. It should be recognised that the usual methods of reliability and validity will not indicate how responsive a measure is to change. Indeed, they may militate against responsiveness by excluding items which fail to discriminate between individuals, but which are nevertheless sensitive to changes within individuals. It will be important for users who wish to apply instruments to measure outcomes over time in the same individuals to examine their responsiveness. Health-related quality of life measures should be responsive to interventions that change health-related quality of life. And evaluating responsiveness requires assessing health-related quality of life relative to an external indicator of change. So in other words, if we implement a treatment with a patient and we ask them afterwards if they feel better, moderately better, or much better, then the outcome tool should reflect that. So measurement tools should be tested on patients receiving treatment of a known efficacy, and hopefully the tool employed will be capable of detecting the treatment effects. There are a number of statistical techniques which can be used as indicators of responsiveness. They are effect size, standardized response mean, and the Goyat responsiveness statistic. And each of these tests will give numbers to the researcher, but really it's the interpretation of what these numbers mean which is the real key. So, how big are different changes? The effect size benchmarks seem to have been set by Cohen and suggested that small effect sizes are 0.2 to 0.49, moderate effect sizes are 0.5 to 0.79, and large effect sizes are 0.8 or above. To give you some illustrations of the use of responsiveness testing, I'm going to give you a couple of examples from the literature. The first of which is the study that Jenny's just been talking about, where they looked at the SF36, short form 36, in multiple sclerosis. As James already talked about, they evaluated the tools for their validity and appropriateness, but they also looked at the responsiveness of the tools. So, in the analysis of responsiveness, they used the smaller sample size of 44 subjects who were tested at the beginning or prior to rehabilitation and at the end of the rehabilitation period. And what they found was that the effect sizes for the SF36 dimensions ranged from negligible to small, 0.01 to 0.3. Of the 8 dimensions, only pain and physical function demonstrated statistically significant changes from admission to discharge. In contrast, the other measures which were compared with the short form 36, the functional independence measure and the London Handicap Scale and the 28-item general health questionnaire, showed moderate effect sizes. The second example is a study by Menz et al., where they looked at the reliability and validity of hip abduction strength to measure disease severity in posterior pelvic pain in patients following pregnancy. The responsiveness of hip abduction strength was expressed as standardized response mean and was compared with responsiveness of the Quebec Back Pain Disability Scale. The responsiveness of hip abduction strength was large, with a standardized response mean of 0.93. In comparison, the Quebec Back Pain Disability Scale gave a larger standardized response mean of 1.2. What's important to point out here is that these two outcome measures are not comparing the same things. The abduction strength is clearly a measure of muscle strength, whereas the Quebec Back Pain is a measure, Back Pain Disability Scale is a measure of pain. So the two tools don't measure the same things, and to compare the two instruments is of questionable value. Changes in responsiveness depends on the treatment, so it's difficult to compare patients who've received different treatment and compare the responsiveness of the instrument. So here we have ulcer medication, perhaps heart valve surgery, shoulder surgery, and hip replacement. And the responsiveness of the SF36 to these treatments is dependent upon the treatment. Similarly, the magnitude of change should parallel the underlying change. This is an example here from perhaps an orthopaedic study where we've looked at the use of a feather, which is the smallest bar there, the use of a rock, a car, and the far bar, a train. It's important to differentiate between generic versus condition-specific instruments. The SF36 is a generic measure and may contain items which are unrelated to the disease being studied. Generic instruments are most useful for discriminating and making comparisons of different disease states, or for determining severity of disease impacts and cross-conditional comparisons. Disease-specific instruments can assess limitations or restrictions associated with particular disease states and may be more responsive to minimally significant changes. Thank you very much.
Okay, thanks very much, Simon. Well, as Simon comes back to join us here, I'd just like to remind you that now's your chance to phone in with your questions and comments on 01752 233 646, or you can email the studio at tvstudio@plymouth.ac.uk, and we'll pass over to Jeremy Hobart in a minute, but we have actually had one email in already during the presentations from Dr. Marcel Eyre in Barnstable, who wants to know about it was from Veronica's study. She was wondering about the number of subjects, and how do you choose to have 10 subjects, and how do you choose to have 3 people doing the different observations? Why not 2? Why not 4? Why not 6? How do you choose?
Thank you for the question. Ideally, there are various recommendations for the numbers of patients or subjects you should have in reliability studies. Certainly, Bland and Altman, who have developed the Bland and Altman test, recommend about 40 subjects for their reliability studies. Other studies recommend 20 to 25. We chose 20 because that's what we were able to do in the timescale we had available. But the more raters you can have, the less the number of subjects you need to have. So that's the reason for using 3 raters for the inter-rater reliability study. But there seems to be there's no general consensus on the number of subjects you use in reliability studies.
So that means, if I can follow it up myself, because I mean that means then that you know, it's pretty much, you know, you can pretty much do what you like in a way. I mean, or is that? I mean, it's not like we say with a sample size. If you're looking for a confidence interval or whatever, you know, you've got some fairly strict rules to follow. Here, it's much more down to what's feasible and what's appropriate for that particular study. Is it?
Yeah, and I think it depends on your sample as well. If you've got a very homogeneous sample, then you may be able to get away with smaller sample size. And if you have very heterogeneous samples, so with patients rather than healthy volunteers, you may need to have much larger numbers of subjects.
Okay, thanks. Jeremy?
Well, I would just say on that, excuse me for sounding like Barry White, but the literature is poor in guiding people on sample size requirements for psychometric studies. And the work that has been done has revolved around achieving certain levels of reliability, which is of course not what we're trying to do. We're trying to understand whether an instrument is reliable or not. If you say that to get a certain level of reliability within certain confidence intervals, you need so many people, you would need to go, no, you're going to have that level of reliability in the first case, which is not really what's happening in instrument development and evaluation at the moment. The rules of thumb, I suppose, are the more the better. The balance between what you can do in a study and the facilities that you have, and some caution in interpreting the results.
I've got another email that's come in, this time from Plymouth. It's a question to Jenny. Can she give us some more information on what influenced her or the research team's decision to use the SF36?
Yes, certainly. The SF36 is really widely considered as the gold standard measure for health-related quality of life or health status, and is used, as I said, worldwide and in an increasing number of studies because it's considered the gold standard. And that is the reason why in our initial study of rehabilitation that we actually used the SF36. And it wasn't really until we were actually using it in our study and examining it really in more detail and seeing the results that were coming through that we felt that we needed to explore it and see whether it really was fit for the purpose of evaluating change in this MS population who are undergoing rehabilitation. And so this was a second study that followed on from our initial study, really to find out more about whether it's fit for purpose or not in the total MS population, but then again, as I discussed, within the sub-samples, because that's really the selection criteria in most MS studies look at quite narrow bands of disease severity.
There's another question also from Plymouth. It's actually in the same email, this time for Veronica. What new knowledge came out of your study? I presume they mean in terms of knowledge about the tools that you were using.
Well, certainly there have been no published studies assessing the reliability of the CODA MPX30 motion analysis system. And if we're going to use it for research and clinical practice and to determine whether intervention has any effect, we need to know the levels of reliability. So certainly the Bland and Altman limits of agreement and the intra-class correlation results give us some indication of the types of error that we're seeing in using that system. So we know, for example, that in healthy volunteers we can expect a variability in ankle angle motion of within plus or minus 7 degrees. So it gives us some indication of the size of errors that we can expect with those measurement tools. and therefore enable us to determine whether there's a real change as a result of an intervention or it's just due to measurement errors.
A question from Exeter, which says, all this research is all very well, but what does it actually mean for clinical practice? How do you, apart from knowing, apart from knowing about the reliability of the measures that you're using, is there something else we should be doing in clinical practice? Anybody want to take that one up? As opposed to research?
I think when in clinical practice, clinicians are always using outcome measures, and hopefully they're using outcome measures that have been demonstrated to be valid and reliable in certain situations. And clinicians should really only be using those tools if they know that they have a certain degree of validity and reliability.
Certainly, you can be doing yourself a great injustice if you're using an outcome measure, for example, that has been demonstrated to be not responsive in the population you're using it, and trying to suggest and then evaluating your intervention with that measure, because you're likely to demonstrate that you've made no change, which would not be good information to give to healthcare providers and would be extremely misleading, since it was possibly the result of the inadequate choice of outcome measure.
I mean, in podiatry, Simon, I mean, in general practice, GPs have to do blood pressure, 3 times, is it, at certain intervals? I can't remember what I mean. I mean, is it sort of fairly normal practice to be measuring things several times and taking the averages, or what?
We use functional foot orthosis quite extensively in podiatry, and these are reliant upon anthropometrical measurements in order to arrive at a prescription. We need to be aware of the limitations of our ability to make those measurements and the error within those measurements in order to build in a tolerance within the prescription and the device that's eventually manufactured.
Can I just pick up on the question? I think the issue here can be stated very simply in that the inferences from trials are entirely dependent on the quality of the instrument that you've used, and Veronica has demonstrated the confidence intervals that you can put around a particular measurement, and therefore the change that you would need to be significant in that group. Jenny has demonstrated that perhaps the most widely used measure is going to give us false inferences, perhaps in detecting change in people with multiple sclerosis. And Simon has just highlighted how important it is to look very carefully at the ability of instruments to detect change, and in fact how difficult it is, because it's intimately related to the change that is induced by an intervention.
One of the things that interests me is this thing about the interval between doing repeatability measures, because I think it was you, Veronica, mentioned this thing that people's if say it's blood pressure, for example, would change over time anyway, and therefore if you measure it once now, you measure it an hour or two later, and how can you be sure that what you're measuring is something to do with what you're doing and then the instrument's doing, or to do with the underlying change? How do you pick those three things out? Anybody want to?
You would measure stability of the variable or variability of that the whatever you're measuring through doing an intra-rater study. If you do things like training, adhering to protocol, and you minimise other errors, then what you're dealing with, what you're looking at, is the stability of the measure. And a lot of things that we look at, like anxiety, they're very labile variables. So it is very important we find out how stable the variable that we're measuring is. That's a key consideration as well. Something like height doesn't vary particularly from day to day, but something like anxiety would.
But also, if we understand the confidence intervals of our measurement, and we see a change which is outside of those confidence intervals, at least we can be sure that it's a change which isn't purely down to the measurement error at that point. I think we can say that to an extent.
How much this thing about the change, and when it comes down to questionnaires, things like SF36, I've used the state trait anxiety inventory, where of course the state's supposed to stay still. No, sorry, the trait's supposed to stay still and the state's supposed to change. And, in the study that we did, the trait moved just as much as the state did. It's quite difficult, isn't it? Because you get the wordings. Because when people, these questions like, what do you normally do, or how do you normally over the last few weeks, or at this moment. I mean, does the SF36 need improving in those sort of wordings or used in different ways? I mean, is that one of the problems?
No, I think the issue probably is that the SF36 is a generic measure. It's designed to measure, to have universal constructs which are similar and relevant across different conditions and different settings. And in doing so, the very nature of it has to be broader. And hence, it's not unreasonable. It's quite logical in a sense that it may not pick up small change that occurs in different groups of people. The issue is that the SF36 is widely advocated as the gold standard measure, and therefore people pick up what is seen as a gold standard measure and use it without really looking at the items and really understanding those items for their particular population. And so even in a gold standard measure, you still need to measure its appropriateness or its relevance for a particular population within a particular setting.
It may be that one wishes to employ a generic measure such as the SF36, and in conjunction with that a disease-specific measure. There's an Australian podiatrist called Paul Bennett who's developed a tool called the Foot Health Status Questionnaire, which the foundation of is the SF36, but it then goes on and has other dimensions which are specific to the status of the foot health status.
I've got a question for Veronica from Miriam McMullen. She says, you use the interclass correlation coefficient. Why not use more common correlations such as Pearson's?
Thanks, Miriam, for that question. The general correlation coefficients have been used a lot in reliability studies in the past, and more recently researchers are starting to use, particularly in rehabilitation research, things like the intraclass correlation and limits of agreement with Bland and Altman. The problem with correlation coefficients is that they're looking at correlation or association between repeated measures. So it may be that you have a good association between, say, morning and afternoon tests, but it doesn't mean that they're in agreement. The advantage of something like the Bland and Altman is that it looks at whether there is agreement between morning and afternoon measures. That's something that correlation won't give you. You may get falsely high correlation coefficients in reliability studies. So it's always important to try and use something like the ICC, but combine it with something like the Bland and Altman limits of agreement.
Jeremy, I was often wonder when you're reading some of these papers about, and you see that a bit of the start of the study, there's a bit which done some sort of validity testing or repeatability testing, and often the results are a bit sort of, well, iffy, and then they carry on and do it anyway. I mean, at what point do you think there arises a situation where a researcher should say, well, actually, I might as well just give up now, this is not worth carrying on?
You mean with a specific instrument?
Well, with a specific instrument, or they've got the best instrument. I mean, supposing they're using SF36, and we're supposing that's the best thing around as far as we know. Is it worth carrying on? At what point do you give up and say, well, I just can't measure this?
Well, I think the first thing to say is that you can measure anything that we believe goes from more of to less of. There are ways of doing that. I suppose there are a couple of issues that I would say here. Firstly, that there are published criteria that you can live or die by, although they are arbitrary as to whether scales achieve or do not achieve certain levels of requirement. And the other issue is to interpret the results within the context of the findings that you have. Mm-hmm. So if you do demonstrate large floor and ceiling effects, you need to build that into your interpretation of the results. If you do demonstrate limited responsiveness, you have to ask yourself, is that a problem with the scale or a problem with the intervention? People aren't changing, or are we measuring the wrong thing? So it's a case of, I think, of adding the knowledge that we get from the psychometrics to the clinical issues that are at hand and marrying the two up to come to a sensible and realistic decision.
Mm-hmm. I mean, joint sort of question really. I mean, the floor and the ceiling effects. I mean, if you're looking at something like patient satisfaction, that's always needed right up the top there somewhere, isn't it? And therefore, how do you get an improvement in it? I mean, what's the trick, the technique? What do you do? I mean, do you change the the words within, I mean, these are generally where you've got a statement and you've got maybe a 5-point Likert scale responding. What do you do? Do you change the Likert scale, or do you change the statement, or do you do a bit of both to try and get around those ceiling and floor effects?
Anyone want to take that?
Sorry?
Well, patient satisfaction is notoriously weak because it seems that most people are satisfied at a certain level, and so it has been suggested that as a variable it is not a good one to measure. The second thing is that if you do have high floor or ceiling effects on your scale, you have a number of options. You can do what Jenny suggests, which is to use other scales that overlap and maybe move higher up and down the variable, or you can consider the process of writing items and adding those to the original scale, but you do force yourself into the corner having to re-evaluate the properties of the instrument that you have changed.
Yeah.
And this is one of the limitations of rating scales. They have a limit, a top and a bottom, whereas the variables that we're measuring usually go way to above and below that, and that the field is moving towards developing banks of items that measure certain constructs and give you a much wider variability, and then using methods to target the right items to the patient. So we have a situation where we have fixed scales that we try and fit to patients, whereas the converse would be more clinically appropriate, that is, to fit the scale to the patient by its targeting. And that's where the field is tending to move at the moment.
And what's happening in, I mean, just to briefly, I think we've got just a few minutes left, and we don't think we've got any more questions coming in. And do, if you have got questions, do phone us or email us, but we've only got about 2 minutes left. You got some centre you're setting up, you set up here in Plymouth, and just tell us briefly about that before we close.
Well, what we are trying to do down here and based around Plymouth, really, which is for two very specific reasons. One is that it's the centre of a very stable population, and secondly, it has an established clinical trials unit based on the cannabis study in MS led by John Zychek, and that infrastructure provides I think a unique opportunity to study chronic disease over time and to undertake clinical trials in large-scale populations. And the third piece of the jigsaw is measurement. And we've seen today that the bottom line is the inferences from the studies are based on the scales. So we need to have better quality scales. And so what I'm trying to do is marry in with the clinical trials unit and the epidemiological work to provide the measurement issues. And that's what we're trying to build.
Okay, well, great. Well, thanks very much. I'm afraid that's all we've got time for in this programme. I would like to thank Veronica, Jenny, Simon and Jeremy, and of course all of you for your watching and participating in this programme. Our next programme is in 2 weeks' time on June the 28th, when Christine Webb will be presenting work from her research study which evaluates the use of portfolios in the assessment of learning and competence in nursing, midwifery and health visiting. So goodbye for now. Thank you. Goodbye.